It is my distinct honor to introduce our final speaker of the day, Dr. Ruth O'Hara, Senior Associate Dean for Research, Director of the Stanford Clinical and Translational Science Award, the CTSA, and co-director of our center. Dr. O'Hara has played a major role in fostering an environment at Stanford in which this type of research is possible. We look forward to hearing about the future vision of the center. With that, I welcome Dr. O'Hara, and just bear with me as I share our slides.
Thank you so much. So I just have to say it is an extraordinary honor to be here with Dr. Williams and the extraordinary investigator she has brought to this effort. You know, I'm at a stage of my career where I'm starting to look back and think about the things that I've done that maybe I think were particularly great contributions. And one of the things that I am most proud of is being one of the individuals who was integral to making sure we recruited and brought Dr. Williams on board here at Stanford. I first met Lee over a decade ago when she was here as a visiting scholar, and it was very clear that she was a visionary leader. Today, we're going to talk a lot about collaborations, the essential component of team science for contributing to all that we do in this space. But it always takes one visionary leader to bring it all together. And Dr. Williams is absolutely that individual, and we're so fortunate to have her at the helm. So I was asked a few years ago to give a presentation on what I believe to be the critical challenges facing mental health. And so I reviewed a number of papers and review papers, and I considered this for quite an amount of time. And there were several central themes that emerged. We have a lack of objective measures that has traditionally been a key factor and limitation. We tend to focus on one domain of symptoms. That has certainly been the case in the past, ignoring often other critical domains such as cognition, or psychological stress, or biological issues such as immune and sleep. We have a need for more deep phenotyping, and genetic markers have been elusive. We have insufficient characterization of trajectories of mental health across the lifespan, and a lack of direct access to the key tissue of interest. And that's been really a rate limiting factor. So if we go to the next slide, how can we tackle these issues? Well, we've seen huge innovative approaches over the last decade, but they still haven't got us to the point of realizing precision mental health and wellness. And I think this center is really tremendously well placed to give us exactly what we need in terms of integrative models and technologies, bringing together the interdisciplinary collaborations that are necessary to achieve that, supporting and a role that I can play with translational facilities, and then having state-of-the-art data science and biostatistical approaches. So if we go to the next slide, I am very much trained in what would have been called cognitive psychology and is now actually called cognitive neuroscience. So when I started, I was very struck at the early stages of my career that we saw cognitive information processing as very distinct from other aspects of emotional processing. So in many fields, it really was not considered okay to really speak to emotion and cognition at one time. And so what has happened is that we've started to learn over the past few decades that actually cognitive functioning and information processing systems, and you've heard so much about that today, are integral to our ability to tackle mental health. They are integral to the profile that an individual presents with when in fact they have a mental health disorder or set of symptoms. So if we go to the next slide. integrating and cognition, we start to realize, has really become essential for understanding mental health. And the advances over the past few decades have showed us that we absolutely need to consider cognitive information processing at the same time, because not only are they related, but they're subserved by the same neurocircuitry. And this comes up in multiple examples. You've seen many of them here today, but in particular, there are many advances in terms of understanding how this is not only important for understanding the etiology of mental health disorders, but also for understanding treatment response. So one of the things that was really striking to me when I met Leanne Williams was that she really understood the importance of the cognitive profile in terms of better characterizing psychiatric symptoms. And that was just very innovative to meet somebody who really understood the cognitive component as an essential feature. So, the next slide is actually referring to work that we have done in my shop. If we go to the next slide, Fausta, on the importance of cognition, not just in terms of understanding etiology, as I mentioned, but also in terms of understanding treatment response. So we were very struck by the fact that older adults have core symptoms of depression that include, of course, often cognitive dysfunction. In particular, their executive functioning, their ability to organize, to strategize, seems to really take a hit as they get older. So one of the issues is, they become less responsive to certain types of treatment. So we had a cognitive behavioral trial, and we thought that it would be particularly important to examine if the individuals who are less responsive to CBT might in fact be those with cognitive impairment. It seemed like a very logical hypothesis, but in fact, what we observed was quite the opposite. We observed, in fact, that individuals who had the poorest executive functioning were the most responsive to CBT in terms of their depressive outcome. And this was really something we were not anticipating. We were very surprised. And we wondered, in fact, if it was because cognitive behavioral therapies actually shore up the response to treatment. If you have a lack of organization, you're having struggles planning and strategizing, cognitive behavioral therapy may actually augment those strategies for you. And so they kind of provide a scaffold for older adults who would otherwise be struggling with those components, making both the treatment and their day-to-day life and problem solving more manageable. So this was really a very important finding where we could recognize that, in fact, even when cognition is impaired, it may be that the particular treatments under consideration have, in fact, a significant positive impact. We go to the next slide. What's curious, of course, is that the same cognitive component and the treatment actually has an impact on the response. So in a pharmacological trial done by Yvette Sheline at UPenn, she found actually a very different effect. She found that speed of processing, slower speed of processing, how quickly you actually encode certain types of information in older adults predicted a poorer response to treatment. And she independently found that brain structure, hippocampal volume, also predicted a poorer response. These were the individuals who are much less likely to achieve remission following 16 weeks of sertraline. And this showed us that it depends which cognitive component we are considering, and it also may depend which treatment we're considering, be it pharmacological or behavioral, what the role of cognitive processing will play. And this started to get to the notion that Dr. Williams has led us on this path of biotyping, that it's not as straightforward as saying, well, if your cognition is impaired, you're going to have poor treatment response for depressive symptoms. It's actually that it's contingent upon the type of cognitive impairment, and also that there are other components such as brain structure and function that may be vital. Next slide. So our conclusions were that cognitive dysfunction may be a significant risk factor for not only treatment response, but also even the development of psychiatric illnesses. That these dysfunctions exacerbate our psychiatric symptoms, and they not only impact our pharmacological and psychological treatments, but they allow us then to actually have a potentially effective treatment for addressing depression through a variety of augmentation and rehabilitation approaches. Next slide. So one way that we've been doing this is actually by looking at brain imaging measures of the response to a treatment or a training plan that actually engages the elderly adult in bolstering their cognitive performance, training them to achieve a better performance in terms of both their cognitive processing, and then looking and seeing that in fact this has a very positive impact on prefrontal cortex, the anterior cingulate, amygdala, and also insula. This is just a very important contribution, and offers us a behavioral augmentation and rehabilitation approach, but it also offers us an opportunity through transcranial magnetic stimulation, an augmentation or approach to actually enhance those domain areas simultaneously. So executive function tasks we find improve when in fact we increase the performance by getting people to practice their focus, their inhibition, their task shifting, their working memory. It's really a very positive benefit. Of course, enhancing cognitive function and has an immediate positive benefit for the emotional regulation. And we have seen that both at the neuronal connectivity level and also at the behavioral level. But those are not the only aspects of training that we can engage in. If we go to the next slide, we find that actually experience shapes our behavioral and neuronal response. So engaging multiple systems, including physical systems, such as exercise, as well as cognitive training, and as well as actually emotional regulation itself, we can enhance the performance by augmenting practice on emotional regulation tasks and coming at the individual's response to treatment, improvement in terms of their symptoms, can capture a variety of approaches that actually augment, in turn, the ability to enhance symptoms and to improve mood. This is a multi-approach that the center is really pivotal in bringing together individuals across multiple domains who can achieve this kind of integrated hybrid approach to improving mood. Next slide. I am particularly interested in life course, and life course is very important in terms of cognition. Cognition is one of the most common components of function that declines with age. It is in fact often self-reported by older adults to be the most perturbing, more perturbing to actually be suffering from impaired cognition with age than suffering from physical disorders. We have collaborated with multiple groups to show that not only can you enhance cognitive functioning through cognitive training, but exercise is a particularly valuable approach to improving the connectivity among neurons and to also improving not only cognition, but one of the most beneficial components for mental health, particularly depression. So making sure that we're capturing cognition and emotion together, not just at one point in the lifespan, but across the lifespan, is really a sort of state of the field aspect of what can be brought together in the center. Next slide. Another domain of research that has underscored for us how cognition is related to emotion was in work that came out in the mid-2000s on the relationship of the serotonin transporter polymorphism to stress and depression. In the mid-2000s was an era when we were very excited in psychiatry that we had actually several candidate genetic markers that would give us more precision around our ability to define who is at greatest risk for developing which mental health disorder and responding best to treatments. The serotonin transporter, if we go to the next slide, is integrally involved in the efficiency of transcription. The short allele in particular, they're just two, short and long, it seems to moderate and modulate serotonin reuptake. And in the case of the short allele, this is diminished. And that can result in extracellular levels of serotonin in the synaptic cleft, which is actually potentially neurotoxic in some cases. So this was a very important finding, the relationship of this particular short allele to increased risk for depression in the presence of stress. But what was very curious in our group when we investigated this, if we go to the next slide, is we found that the serotonin transporter short allele was also integrally related to delayed verbal recall and also waking cortisol levels, which are the stress hormone. And these two in interaction really conferred a significant decrease in verbal memory. So it further underscored for us that, in fact, having the short allele put you at increased risk, not simply for depression in the presence of stress, but also impaired cognition, leaving open the question of whether, in fact, the cognitive effects are mediated by stress, or in turn, whether the emotional effects are actually mediated by impaired memory. So this was really a striking finding. I had a very interesting conversation with Leanne Williams at the time, because if we go to the next slide, we moved to a model very quickly of moving away from candidate genetic markers and moving to a model, of course, of whole genome sequencing, a much more in-depth and robust phenotyping of the genome, and trying to grapple with that at the individual level. But we sort of ignored and stepped away at that time from candidate genetic markers. And I talked to Dr. Williams about this, and I think it's a measure of her vision that she really understood that the contribution that even these broad candidate markers could make to our biotyping, and that we held ourselves in psychiatry often to a higher standard for identifying potential biomarkers, particularly as they work with other domains of symptoms and cognition. And that was, I think, a fundamental building block of the thoughts for putting together the center. So if we go to the next slide, team science is, of course, essential to building a center approach to gain the complexity of insights that we need to integrate these domains. And Dr. Williams was already at the forefront of trying to do that. While we might employ candidate gene markers that have been well documented to impact psychiatric functioning, such as the 5-HTT-LPR or APOE in the case of cognitive impairment and cognitive decline, I have to say that she had the vision to recognize that we need to bring these all together at the same time in the same individuals, and that this could be utilized to produce a biotype that might far better inform us in a more precise manner, really achieving the goal of precision mental health. And to that end, she's brought tremendous numbers of individuals here, together a fabulous investigative team, many of whom are tackling the specific domains, but also integrating them with others. So one of the biggest challenges in the field of mental health is actually getting back to the level of the cell. So the basic science approaches in mental health have often remained distal from the brain and the behavioral phenotyping. So if we go to the next slide, one of the challenges is how do we get further into the brain neurocircuitry at the cellular level and the neuronal functioning to better understand what particular aspects of that functioning is in fact bestowing an increased risk for the development of a psychiatric disorder, or telling us who is going to respond better or not to treatment. And this has been one of the biggest challenges compared to other fields, unlike cardiovascular medicine, for example, unlike the domains of oncology. We in psychiatric disorders do not have direct access to brain tissue, except under the most extreme of circumstances, when somebody suffers a traumatic brain injury, for example, or when they have a premature passing due to suicide, which is really one of the most troubling components of depressive disorders, is in fact the risk for suicide attempt. So how do we get down into the cellular basis to better understand the etiology of these disorders? And it's important to recognize one of the reasons it's so important to have access to the brain tissue that we are really looking at as part of the organ of interest is in fact to be able to understand how the genes express. Gene expression is tissue specific. So this is a real important component that had been significantly rate limiting in the field of psychiatry. If we go to the next slide. So we did a study actually on older adults who were coming in for a CBT, and we looked at their responses, their brain imaging responses to CBT while in fact engaged in an executive functioning task. And we found that these were very heterogeneous. So on the one hand, we use brain imaging to try and define what's going on. The sample sizes we would require to understand at a cellular level are actually significantly high. Often, this is not something that's feasible. So even though the findings here were that certain patterns, and if we move on the slide, actually of brain imaging, particularly in the prefrontal cortex, were predictive of treatment response to CBT, there were so many variations that it would be very challenging to create a biotype from this information. Next slide, please. So we recognize it's really important to have a multimodal and dimensional approach to understanding psychiatric disorders. So in the last decade, in 2007, moving to the next slide, we had one of the most significant advances in the field of psychiatry, which was the ability to utilize induced pluripotent stem cell models to derive neurons and examine the function of those neurons in a dish. This has been a model system that has been adopted in every domain, but it's particularly important for us in psychiatry because we have the opportunity for the first time through just a simple blood draw and very complicated techniques subsequent to that to actually derive from that blood sample the fundamental stem cells from which all other cells are derived and grow up neurons from the individual patient that we are actually examining in a clinical trial. And in fact, if we go to the next slide, one of the most valuable components of growing up neurons from our patients with these psychiatric symptoms is we can also examine in the dish the response to various treatments. Here's wonderful work from Fred Gage and his group on altered serotonergic activity in individuals with treatment-resistant depression. This is a model that we have adapted in our own labs here, and we go to the next slide. We have an ability here to actually derive eye neurons. There you can see these are eye neurons from individuals who have participated in our studies that actually show activity. This is calcium imaging to show that these neurons are actually synchronous and showing spontaneous network activity. It's a really powerful model. It's not a complete model. It's a model that's still in works, but we are already finding very significant opportunities to examine many of the theorized and hypothesized etiology of something like depression or anxiety in the dish. In fact, one study in the next slide you'll see that we're doing is a stem cell model of examination of stress response in depression. So we have depressed patients and also healthy controls who participate. We derive the neurons. We actually grow them up over 28 days. And then we're able to examine the gene expression from those neurons with and without exposure to stress hormones. And this is also a model that facilitates treatment with multitudinous treatments that will be extremely beneficial for really bringing tremendous link between the cellular level and the clinical level in real time. Next slide. So just probably can't see this because I'm not sure the videos are working, but for some of our older adults, we already have this stress model. And these are neurons that if you press on the video there, you can see are actually firing synchronously with each other from a participant in a study. And this is just a tremendous opportunity to be able to get a cellular level at the same time as we're achieving the imaging, the cognition, the emotional regulation, and the clinical symptoms. Next slide. So where do I come in terms of my role in contributing to the evolution of this center? Well, in addition to having teams, we also have to have facilities and resources. I am the leader of the CTSA, which is our Clinical and Translational Science Award, funded through the NIH, that brings a tremendous number of opportunities, facilities, instrumentation to our research teams across the School of Medicine, and in this case, specifically to support the work of the center. We have so many opportunities here, if we go to the next slide, where we can really contribute tremendously, I believe. We have new cryo-EM machines that are being deployed as we speak. We have the latest and greatest in many genetic domains, full whole genome sequencing through our core facilities. There is a smorgasbord of resources that often I think we are not always as good at communicating about as we could be. We also have a tremendous amount of opportunity to engage with individuals working in domains such as compliance, to understand and have support for the mechanics and the administrative components of organizing and supporting clinical trials. Our clinical trial platform has grown tremendously in the last decade here at Stanford. Next slide. We have a clinical and translational research unit where you can actually go and get an approach with bringing your patients, having your patients have blood drawn, have the assays performed that you need, have the DNA stored, have nursing support, research nursing support for those studies. And we will certainly be providing those resources here for the Center for Precision Mental Health and Wellbeing. Next slide. This is our clinical research unit where there are clinical research coordinators who are able to engage with and produce a much more rapid process for getting that all-important IND, for having financial support in terms of what's the contracts that need to be signed, for supporting recruitment, for supporting scientific review. These are all of the resources that we currently offer. and really also underscoring the compliance components. It's often the more boring stuff, but it's the essential stuff for creating good centers. Next slide. We have a precision health biobank. This already supports over 100+ faculty projects, while also helping advise Stanford as to the next generation of life science data solutions. It's an excellent biobank, and it was integral, if we go to the next slide, in helping us achieve and be at the front lines when it came to actually taking specimens with respect to COVID-19 and getting a much better understanding of infection recovery. This is one of the IRIS neuro study was at the forefront of nationally. And as a result of that, we in the biobank really got a tremendous amount of additional recognition and support because of this win-win collaboration. One of the other components, and I mentioned it as my fourth component, is the essential glue to having this integration among multi-modals, multi-dimensional data, deep phenotyping, to bring that into a pipeline that can be operationalized to improve clinical care and treatment, actually requires state-of-the-field bioinformatics. And this is a domain also in which psychiatry has been behind our other domain areas such as cardiovascular medicine, oncology, to name a few. We have tended to be very cautious about moving away from a hypothesis-driven approach to a data-driven approach. The amount of data that we have here to integrate and to yield precise phenotypes that capture everything from the cellular level, the genome, the neuroimaging, the EEG, the clinical profiles, the cognitive profiles. We need a significant data science, data-driven approach. And we have excellent collaborators here. Sylvia Pleveritis in the Department of Bioinformatics and Data Sciences has an extraordinary faculty, always eager and interested in bringing their expertise to these issues. We have, as part of our clinical, our informatics core, we have Nigam Shah, who is renowned for actually developing bioinformatic approaches that can bring together clusters of phenotypic information that can give us much more precision about how a particular patient is doing, what their prognosis is, how they're responding to a treatment or not. And I think it's a very innovative component of the Stanford Center for Precision Mental Health and Wellness that we are actually heavily engaged with really state-of-the-art, nationally and internationally, experts who can help us have the techniques from a bioinformatics perspective that will allow us to optimize the biotyping that we will achieve in the center. And this is just an example of some of the issues that we deal with. You know, even something as simple as design needs that informatics approach. We have shown over the years that if you actually just do a prospective study, there are many flaws with that study. If, in particularly with the interpretations, if you don't have the information that and the design from a bioinformatics perspective that sets you up to get the best yield on that data. And we found that actually by structuring our designs ahead of time, we yielded more precise and accurate information that gave us a very different picture into the etiology, in this case of Alzheimer's disease, but this can be applied also fully to psychiatric disorders. So with that, I'd like to conclude and say this is a very quick view from 40,000 feet to thank you so much and ask you to join us in creating the future and collaborative mission of the center, taking us from the biotyping right through clinical and field translation, It takes a village, and Dr. Williams has assembled an extraordinary village here, but it's her vision that is the fuel that is driving us and bringing us together, and we're extremely grateful for that. Thank you so much, and apologies for the glitches at the beginning.